just use the audio from my computer if it's good enough.
Yeah, it sounds great.
Okay, good.
And we have the go-ahead. So I'd like to welcome everyone here this evening, and I apologize for the technical delays. So thanks very much for your patience. I'd like to welcome you to our presentation this evening. And my name is Chris Malloy. I'm a certified financial planner and senior advisor at TMFD Financial. I'd like to start off by thanking you joining us for the webinar this evening. And in a moment, I'll introduce our speaker, Dr. Murray Arlen. But first, I'd like to briefly introduce TMFD Financial and explain the valuable services we provide to clients. Our goal is to make the financial lives of our dentists simpler by combining a variety of services under one roof, from tax, investments, insurance, and other financial planning matters you may have. Additionally, we can coordinate with other professionals that you may need, for example, lawyers or mortgage brokers and bankers, to ensure all of your current and future needs are covered. In our experience, we found that providing these resources as a one-stop shop for financial solutions provides you with the comfort of knowing that all aspects of your financial career are synchronized. And the result is simplicity, peace of mind, and confidence in your financial decisions. In addition, TMFD Dental Academy hosts webinars like this one this evening to enhance your clinical education and knowledge of wealth management. So at this point, I'd like to hand things over to my colleague, Aaron Carballo, who is managing the technology for us tonight, and to provide some housekeeping items. There we go. You're on mute.
Sorry about that. So before we start, as Chris was saying, just a few housekeeping items here. So for those unfamiliar with Zoom webinars, if you have any questions for Dr. Arlen or Chris, you have an option at the bottom of your screen for a Q&A button that will send it directly to Chris and Dr. Arlen. If alternatively, you do have the option to raise your hand and we can call upon you and we can unmute you if you would like to ask your question directly. And the third option is a chat button, which would allow you to communicate with anybody in the webinar if you want to send it to everyone, or you can also change that setting if you would like to send it directly to the panelists or myself. And that's it.
All right, very good. Thank you, Aaron. Okay, so I'm really pleased and excited to introduce our speaker this evening, Dr. Murray Arlen. Dr. Arlen is a periodontist that has practiced dentistry for over 40 years. Throughout his career, he maintained extensive records of his patient treatment. And tonight, we have the benefit of Dr. Arlen's experience and insight, as he will share with us a couple of case studies that were monitored over that period of time. These cases involve periodontics, orthodontics, conventional prosthetics, and implant dentistry. In addition, they include unusual diagnostic challenges and treatments. But on a personal note, Dr. Arlen, I'd like to add that you've been a tremendous ambassador of TMFD over the years. And I think sharing your knowledge and wisdom during the webinar this evening is just another example of that. So from all of us here at TMFD, we'd like to thank you again for your continued support.
Thank you very much.
Yeah.
My turn?
Over to you.
Okay, thanks. And I'm going to share my screen right away as I'm talking. If we can enable the screen sharing, please. Everything that Chris said is true in that they offer really a full service. And I will make a disclaimer that I have been a client for many years. And I'm really, really super duper pleased, to say the least. And so I have no hesitation 100% of supporting them and recommending them. So thank you, Chris, and thank you, TMFD, for sponsoring these webinars. So Chris already mentioned our topic, and this again is just a little disclaimer that I have in the middle. I do have an extensive testimonial if you want to read it on their website. So I've helped organize this academy, and we do about 8 topics per year for our dental, for our wealth management. And it's a great service. So welcome everybody. Thank you for attending. And this is what's on the website. And Chris already mentioned these outlines. A lot of the treatments you'll see are what I call patient-centered treatments, not always the ideal. You may be a little surprised at some of the things we've done. But the key with these two cases is I have 33 years and 41 years of follow-up. So I think this will be a little different from most lectures that you see where there's only short-term follow-ups. And the reason I want to show these cases is to really concentrate on a theme of trying to get a knowledge of the long-term survival and loss of natural teeth versus implants. I say versus because this is a critical knowledge for you in making everyday clinical decisions, whether you want to save the tooth or whether you're going to recommend extracting it and replacing it with a dental implant. Now, with many things in dentistry, opinions and the pendulum so-called swings too far in one direction and then the other direction. And this topic is also like that because we have to ask ourselves when we compare the longevity of teeth versus implants, helping us decide to extract an implant or save the tooth. You know, have we become too optimistic with implants and too pessimistic with teeth? And I look at some cases I've seen where patients have been recommended to remove all their natural teeth and do implants in a day type thing, sometimes, in my opinion, too aggressively. Or alternatively, have we become too optimistic with teeth and pessimistic with implants? That's a lesser common attitude, at least today with implants being so popular. But I'm going to digress for a moment and just delve into this aspect. There's this article that came out that said dental implants fail at 10 times more than natural teeth. Was an advisory comment by Scott Fromm. I'll just tell you a little bit about it. His comments were based on an actual article, Guarnieri published in 2021, stating this. So myself and my colleague Emil Svoboda decided to really analyze this study in great detail, and we published sort of a commentary on what we thought about this. And this is a busy slide, don't worry. So the top is just the article I'm referring to, and I mentioned the opinion by Dr. Svoboda and myself. Here's the bottom line. We concluded that this title is really misleading, and we felt that the study, when you really looked at it carefully, the data did not support this sensationalistic title. Now, I'm not going to go into all the defective aspects of the study, which I list here in bullet form. You're welcome to go back to the recording or feel free to email me if you want to discuss this in more detail. But the bottom line is I felt this was a very misleading, sensational title. Now, again, just a little bit more on this topic. And again, another busy slide, but I'm not going to bore you with references to numerous publications, but I will mention in terms of the longevity of natural teeth and implants, if you look to the bottom here, and this is a compilation of many respectable studies and my own clinical work as well here in the yellow, you get kind of a range of, let's say, a 10-year survival rate for teeth. Depending on the study, the failure rate's around 2 to 5%. In my clinical study, my implants are 5.25%. 10 years or more we're talking about. And other studies, it ranges 2 to 8%. But notice in red, if you see this is a higher percentage if you're looking at just patients with aggressive periodontitis. So let's go back to this importance of interpretation of these numbers. The numbers I've just gone over with you are average rates. But really survival rates can vary dramatically depending on the individual's risk factors. For example, if we look at susceptibility to caries or periodontal disease, and you see here in red aggressive disease, the failure rate's almost twice. And so we really have to look at our patients on an individual basis and not apply average rates to each individual who may have fewer or more risk factors than the average. So remember, when you're making a decision on your patients to suggest extraction or saving a natural tooth, you want to have knowledge of what these risk factors are. Now, I have 30 hours of material on risk factors, and that's not our main topic for tonight, but we'll touch upon two cases that have the risk factors of caries and periodontal disease. And you're going to see how the percentages are not close to what these averages are. So again, the importance is the interpretation, as I've mentioned. Well, we're going to sprinkle a few multiple choice questions that you have to answer. And if Aaron is helping to bring that up, thank you. It doesn't matter whether you answer them right or wrong. No one's grading you on that, but you have to record an answer. So TMFD has proof that you're at your computer. So please answer. So concerning the longevity of natural teeth versus implants, is this a knowledge of anticipated longevities should influence the long-term survival rates? Is that true or false? Number two, when you see articles in journals, could they be misleading? Should you read the article more carefully? Is that true or false? And if they're both true, you should answer C, because C is, I mean, the better answer if you believe A and B are both true. So we've pretty much got everybody responding, and A and B are both true. So the best answer is C, but you can't really answer incorrectly. So we're going to have 7 of these questions sprinkled throughout the presentation. All right, let's introduce our first case, which is a 33-year-old follow-up on both survival of implants and natural teeth. Here's the basic history of, I'll call it basic and emergency dental care up until the patient was about 55. And at that point, I graduated dentistry in '77. And at that point, I referred this patient to a local prosthodontist who did full mouth rehabilitation, crowns on every tooth. This patient, risk factors leading up to that, many heavily restored teeth, many endos and surgical endos, a heavy bruxer, history of recurring caries, and developed diabetes, which I think accelerated things later in life, as you'll see. So we're going to look at this case with the multidisciplinary treatments, as Chris mentioned at the beginning, and we have a 33-year follow-up until the patient deceased in 2011 at page 86. Now, with both these cases I'm showing you, I did actually publish an article on these cases, which if you email me, I'll be happy to send you the digital versions, as well as any of my other studies on risk factors and stuff. So this is just a picture of that article. I show it here. And I want to tell you that it says right here, the patient was the author's father. So this is my father's case I'm going to show you. My father would have been pleased to see this article being authored by his son as a tribute to him. And my dad would feel very happy if he could be helpful in helping other people. And hopefully there's something you can learn from that. And out of respect to my dad, hopefully he would be happy about this. So he had his full mouth rehab done in 1978. It was completed. And so this is my first sort of record of him 7 years after this full mouth rehab. And you can get an idea that there's lots of endos. You see surgical endos, you see a lot of missing molars. Even the 35 here is missing. There's cantilever. I can tell you there was a lot of attrition, both occlusal and interproximal, a lot of root proximity. So a tough case. And I'm going to show you now full mouth series taken 10 years later, or 17 years after the initial prosthetic rehabilitation. You can see that I've got a couple of X's on the molars. I'll show you some close-up periapicals in a moment because there was severe decay and bone loss. And we've got extractions at the 4-1, 4-2 because of decay that you can't see clearly here. By now, we had lost the 3-4 and the cantilevered 3-5. And this periapical is actually taken about 8 months after the extraction. So let's look at some of these areas in more detail with the periapical. So on your upper left was from the full mouth series taken 7 years after the rehabilitation, and things holding up reasonably well. A lot of root proximity here. It's kind of hard to appreciate how tight the teeth were. He had difficulty squeezing a toothpick in between the teeth. But look 10 years later on the upper right, and you could see the significant bone loss, and you can sort of see the decay. And you can see on the lower images that it was just not possible to salvage these molars, so they were removed. I put timelines and everything. So here again on the upper left was from 7 years after rehab in 85. And then this again is 9.5 years later, just before the 34 was removed. Because remember, this Vilma series I showed you, I said it was 8 months after the 34 was removed. So obviously we removed this and we waited about 8 months and then did a linear tomograph, because that's the technology of the time in 1995. You can see here how there was decay on the 3-4, and that just fractured off, the solder joint fractured, and that was the cantilever 3-5. So let's look at this lower left area first. This is clinically what it looks like about 8 months after the extraction. And we're going to do implants here. And you can see on the upper left, just before we started our surgery, but again, this is 17 years after the initial rehab was done. Look at the wear and the repairs that were done. I said he was a severe bruxer. So we'll come back to this, but bruxing is one of the documented risk factors for certainly mechanical complications, if not also biological complications. And by biological complications, I mean bone loss and implant failure. Mechanical complications is component breakage. Anyway, here's my 3 osteotomies. And here's the implants just as they're placed. And we're going to revisit this case, but I'm going to ask you to take a close look at these 3 implants. And I'm going to tell you one of these will show progressive bone loss over a period of 16 years. And one of them will be removed after 16 years. Can you guess which one it is? We'll come back to this case, but choose one and hopefully you have a reason, and we'll revisit this case. And then the lower right is just a few months later. So these are Straumann 1-stage implants. Those of you who have been around long enough know this is what the healing abutments or cover screws looked like in those days. So now we're jumping ahead about 6 months. We've already got the abutments connected to the implants. We've removed the 4-1 and 4-2 that I said before had to be removed. All the old crown and bridge is removed. The preps are refined. And we're going to restore the full mandibular arch. And how are we going to restore that? This just shows you what are called synocta abutments. The framework was first made for the natural teeth before this slide. And now the metal framework for the natural teeth is going to be picked up along with the implant. So there's the implant pickup impressions. And there's the impression with the analogs in place. So I'm not going to go through all the prosthetic steps. First of all, as a periodontist, I did the surgery. I did not do the restorative, so you'll forgive me if I make some restorative terminology errors, but you get the idea. I'm just briefly showing you some of the prosthetic steps. But remember, this is done in the 90s, so we didn't have digital technology. Now, this is our master model with the framework and with the abutments. This just shows you how the abutments are protected. So now on the implant section, the metal framework is being made that's connected to the abutments. Now the porcelain's been applied. We're making sure it's cleansable with a Proxibrush, et cetera, et cetera. And that's what the final new mandibular restoration looks like. And remember, this is now 18 years after the first rehab was done. So the mandibular rehab lasted 17, 18 years. And we've got the 3 implants here for a 3 implant splint at the 3, 4, 3, 5, 3, 6 area. And then we've got a natural tooth splint running from the patient's lower left cuspid, the 33, all the way to the 45. And we've got a small cantilever 46. So here's what it looks like clinically. The upper left before the access holes are plugged. It's a screw retained splint on the lower plugged, and you just see the buccal and the lingual view. Pretty straightforward. Here's what the radiograph looks like just soon after the 3 implants were restored. But here's a question I have for you. Here's the natural crown and bridge done on the remaining part of the arch, starting at the 33 and extending all the way over to the 45 with the cantilever 46. So this is just the day the prosthesis is inserted. You can even see there's some excess cement. So here's my question to you. On the natural teeth that were decided to be saved, do you think that was the right decision? Based on what you've seen so far, do you think at that point we should have taken out all the teeth and just done implants? Or do you think that that was appropriate decision? Again, what I was talking about before, we need to make a decision. What's appropriate? Save the natural teeth or extract them and do implants. Now, we will revisit this case. We'll see what happens down the road. But again, I want you in your mind to decide what would you have recommended. So let's remind ourselves what we started off with 7 years after the initial rehab in 85. 10 years later, we're going to lose the molars and the 4142. We've lost the 34. And we've placed our 3 implants and we've redone the mandibular prosthesis on the natural teeth. We've removed the upper left molars, and that's still the original crown and bridge from 18 years before. So are we done? Well, this is a pan. Let's check the periapicals to get a better view, starting with the upper right bicuspid. This has taken the same time as the Panorex I just showed you, and we say not so fast. We're not done yet. 18 years following the initial rehab, we see some serious root decay and bone loss. On the 15, a year later, 1997, the bone loss is worse, the root caries is worse. It looks like we have a fracture. Now remember, this patient's a bruxer. We even have root caries on the mesial of the 1-4, which doesn't show well, so I'll show you a different view. There you see the root caries better. You see the 12 and the 11 endo treated, maybe a perforation. So we're thinking, how are we going to treat this upper right section? Now here's the upper left at the same time period, and it looks like there may have been a perf. Bone seems okay. So this left side's looking better. So now we're thinking, if you're thinking, well, we have to do extractions and implants on the right, what about the left? Just like the mandible, I want you thinking, if you're going to remove the teeth on the upper right, what are you going to recommend on the upper left? There might be some decay going on down here. Well, here's what we decided to do for the maxilla. Remember, this is 97. Now this is 19 years after that initial rehab. The lower's been done already for a couple of years. So here's the steps we're going to take. Number 1, we temporize the whole maxilla because he doesn't want to wear a removable interim. Step 2, we're going to place implants in the upper right side from the 16 to the 12 area. We decided on the 22 to 25 area to redo the prosthetics on the natural teeth, just like in the mandible, the way we saved the teeth on the lower right. And we'll revisit later to see if we made the right decision. And 11 and 21, with all those endos and decay, we're going to remove the centrals and do a separate 2-unit implant restoration. So we temporize the maxilla. Step 2, let's look at how we treated the upper right, because we did something a little different. You may have heard something called staged treatment, where a patient doesn't want to wear a removable appliance, and we're going to use teeth that we will be removing later, 14, 12, and 11, as temporary natural abutments for an interim fixed bridge. So we can place implants. This is step A and step B. It's a 2-step procedure. Step A is the temporization I just mentioned, and placing implants at the 13, 15, and 16 sites that will lay buried. We're not doing immediate restoration on this patient who's a bruxer. So again, this is just a Pontic site, believe it or not. And these are the teeth that will be removed later that will act as a temporary abutments for an interim fixed bridge. And we're going to place those 3 implants I mentioned, and then put the temporary back on top of those and let them heal in an undisturbed fashion. This is just a little placement guide. So we'll take out the 14 and the 12 and 11 and 21 at a later date. So here's what it looks like the day the implants are placed. And the temp goes back on over the top. We'll come to the left later. And here's what it looks like a few weeks later with soft tissue healing. And here's what it looks like after about 4 months, where the first 3 implants we place have integrated. Now we want to go to step B. So now we're going to make a second temporary bridge on those first implants that we placed that have integrated, and we're going to remove some additional teeth and place additional implants and let them now be buried under the second temporary. So obviously costs more, take more time. But you may ask yourself, do we even need an extra implant at the 14 area? Because we have one on the 13 that's off the screen. We probably didn't, but the price was right. 4 times 0 is the same total as 3 times 0. Remember, it's my dad. And he's a Bruxer, and we're going to over-engineer. So there's the implant at the 13. These teeth will be removed later. See very long implants. So here's what we've got when these implants are integrated. We're ready to make the second temporary. And in position, the edentulous position 14, we'll place an additional implant buried underneath the second temporary. So you get the idea. So that's step B. So we take out the 14, doesn't come out so easy. And I put another implant in at the 14 site, and this is after a few weeks of healing. And here's the extra implant at the 14 site. Note, I did come a little close. We didn't have navigation and guided surgery in those days, but no problem, but certainly nice if that were a little distal. The implant at the 1/6, the bone was really soft. So I said, you know what, even after 4 months, let's let it sit a few more months. So let's make our temporary from the 15 to the 13 and leave the 4 and even leave the 6 too. So you see, we've got the temporary abutment on the 15, we've got the temporary abutment on the 13, and that's what's going to house our second temporary. The dentist, by mistake, torqued on a synocta abutment on the freshly placed implant at 14. Shouldn't have done that. It was a mistake. Didn't turn out to be a problem. I mean, I don't like putting torquing pressure on an implant until it's integrated. And the next step is we're going to remove the 12, and we will later remove the 11 and 21 as well. So here we are, an extra few months down the road, and we're going to complete the prosthesis on the right side on the 4 implants, 16, 15, 14, 13, and we're going to just do a cantilever for the 12. We don't need another implant there. So there, again, a few prosthetic steps, just showing you the pickup impression, the synocta abutments on the master model, the framework, the 2 views, and there's the radiograph of the framework try-in for the 4 implants, and there's just showing you some of the lab work. And you get the idea that that 12 is now here cantilevered. So we're over-engineered for sure. And we certainly didn't need, you know, that middle implant at the 14 site, at the 15 site or 14. Could have done with 1 less. So now we're on to the next step. We're ready to redo the left side. And I mentioned we're going to do that in a conventional way. And I ask you the same question like I did in the mandible, and we will revisit. Did we do the right thing by just redoing the crown and bridge? Or do you think, based on what you've seen about this case, we would have been better off to bite the bullet and just take them all out and just do full mouth implants? So we'll revisit, we'll see what happens. So here's what it looked like 19 years after the initial full mouth rehab. We redid this left section while we were doing the rest of the arch, and that's the new bridge, the redo bridge, as I like to call it, 1 year later. Looks fine. And then the last step I mentioned for the maxilla was doing the front here. You could see that 11 already had been lost at this time, and you see the decay at the 21. And this again took out the root, did a couple of implants. He did wear an interim removable for that. And again, a few prosthetic steps, which I'm not going to go over with. That's not the focus of this evening. And as I mentioned, I'm not a restorative dentist, but you get the idea. Okay, great. 21 years after we had that first rehab, we've redone the whole mandible with 3 implants in the lower left, and now we've redone the whole maxilla. Okay, so a couple of questions about stage restoration. What does this mean? Concerning stage restoration of dental implants, does that imply the use of some natural teeth for an interim prosthesis while the initial implants are healing? True or false? Does that imply the use of osseointegrated implants that have healed to be used at a later date for a second interim prosthesis while additional implants are being placed? Or is the best answer that both of those are true, in which case you would select C? Okay, so They're both true. So A is correct, but C is your best answer because they're both true. Okay, let's move on now. And again, let's remind ourselves what we started off with in 85. And here's where we stand now. As I mentioned, 21 years after that initial rehab, we're 1 year out with the maxillary rehabilitation we just covered, and we're 3 years out from the mandibular restoration that we did. Finally, you know, we hope we're done, because this is costing me a lot of money. And it's not costing my dad a lot of money, it's costing him a lot of time. And this is the same time frame, just a Panorex. So again, I ask you, now are we done? Well, the lecture's not over yet, so no, obviously. Let's go revisit the mandible now. And remember I said, did we make the right decision in saving these natural teeth when we redid this prosthesis? 3 years out, it's looking pretty good. But let's see what happens an additional 3 years out. 6 years after this brand new bridge was in place, my dad comes back from Florida with the bridge in his hand. And you can see these teeth were not salvageable. And he just rocked that thing right out of his mouth. So now we're going to remove all the rest of the mandibular teeth. Remember, we have 3 implants we placed in the lower left. We're going to remove them all, and I'm going to place 6 implants. Remember, this is 6, so that second bridge lasted 6 years. The first one lasted 17 years, I think it was. The second one lasted only 6 years. So we placed 6 implants. There's the 3 original implants. We are going to do immediate restoration as well. 3 of these implants were immediate extraction socket placements, 3 were in healed sites, but we've got 6 implants with a good cross-arch stability, a lot of support. It's 6 years now since the first implants were done, and we're going to do immediate restoration. Now, I'm not going to give a whole lecture on immediate restoration. We talked about staged implant treatment. Now I want to mention a little bit about immediate restoration. There are risk factors such as bruxism and poor quality bone, which the bone at the molar site wasn't the best. How do you try to compensate or mitigate the risk? You over-engineer, like we did in this case with 6 implants. We had cross-arch stabilization. We're going to make an immediate, fixed, very rigid wire reinforced temporary. You want something rigid. We're going to put most of the occlusion on the integrated implants from 6 years prior at the 3, 4, 3, 5, 3, 6, a night guard. And we're not going to do the definitive prosthesis. You're going to wait 5 months.
All right, before you go on, we have a question. And the question is, why switch implant systems?
Well, I mean, gosh, thank you for the question. It's certainly off topic, and I could spend a very, very long time. I've used, you know, maybe 8 different implant systems over my career. And as time goes on, you sometimes are using implants that may show some problems that you didn't anticipate. Some of them only show several years down the road. And you get introduced to other implant systems that you feel are better. So, you know, if I have 5 articles on the evolution of implant dentistry. Some of them show some old surfaces that had 25% failure rates, but after 3 to 5 years. Well, you don't know about that right away. So maybe that's a topic we could have for a different day when I can spend an hour and a half on that exact question. Any other questions, Chris?
That's it so far.
Okay. Again, I'm not going to belabor the point of the prosthetic steps, of all the components you need for an immediate fixed temporary. I'm just going to zip through this. This is just showing you the temporary in place. By the time we got it back from the lab, I think it was 2 days after the surgery that this temporary was placed. And it's not easiest. My father was a tough patient to work on, very short teeth. But you see the implants, the way they were placed, and you see the immediate fixed temp bridge. And then he went on to have the definitive prosthetic treatment done. And I'm not going to comment on the prosthetic technique because I didn't do it, and I can't explain it, but you'll see that the prosthesis was divided up. We have the lower left, which was the original 3 implant splint. And then the new implant sections was done in 2 sections. You see here from the lower right to about the lateral area. And then you see it was split up into 2 sections. And the details are not so important, but you get the idea that we decided to remove the remaining natural teeth. And again, the interesting thing here was that it was an immediate restoration, which frankly, I'm very cautious about, but I did it in this case. I didn't have to worry about a lawsuit from my dad if it didn't work out. Just showing you a close-up view of the definitive prosthesis. We're getting some more recession here. Aesthetics is not an issue in this case. And this is what it looks like with the definitive prosthesis in place. And you can see that now it's 6 years and we're starting to get some bone loss around that middle implant. Remember, I asked you which implant do you think will have bone loss, and we'll revisit this more carefully. First, another question concerning immediate restoration of implants. True or false, does that imply the use of natural teeth for an interim prosthesis while the implants are integrating? Or is that stage treatment? Giving you a little hint. Does that imply restoration of implants immediately after they are placed? So is A and B true, or is it just A, or is it just B? We're getting a little more variation on this one. Okay, so A is referring to staged implant treatment, like in the previous upper right maxilla, not immediate restoration. So B is correct. So the proper answer is B only. Okay, let's move along. Another question concerning the risk. Hold on, let me. Yeah. Also concerning the risk of immediate restoration, concerning the risks, are these things that we can do to mitigate the risk? Over-engineer, cross-arch stabilization when possible, a rigid interim prosthesis, reduce the forces on implants, or are all of these true? Bing, bang, boom. Good. So they're all true. So the best answer is E. You see that I move at a very quick pace. Okay. Now let's revisit the lower left because it was disheartening, I'll say in hindsight as a teaching case, fascinating to see of these 3 implants, how the middle one over time, 6 years, 15 years, 16 years, was showing this ongoing bone loss. And they're all the same kind of implants. They're older Straumann kind of implants. At that time, they had a TPS surface. Now they have a surface called SLA or SL active. So let's re-show that slide I showed you before, the day we placed the implants. Remember, I asked you, guess which implant might show bone loss and will eventually have to be removed 16 years later. And if you guess the middle one, you're right. And why? Well, look how the bone is thinner here. That might be the case. We don't know that for sure. The TPS coatings weren't great. And I suspect some of those TPS coatings were too thick or defective. We'll never know for sure. But just to digress for a moment, you see the pus coming out and 12-millimeter pockets. So I just sectioned out that implant initially, and then after it healed, the prosthesis was redone. So in hindsight, we were lucky that we did over-engineer the case because we could salvage that case prosthetically without having to redo an implant. But let's digress for a moment on the potential etiology. If the bone is thin, a lot of people don't realize this. When you finish drilling your osteotomy for your implant, if you leave less than 2 millimeters of residual bone on the facial surface, it may look good the day you place the implant, but as it heals, you're at higher risk of getting bone recession and accompanying gingival recession. And you end up with cases that look something like this. These don't happen to be my cases. The TPS coating is another issue, and I did publish an article on this, comparing my Straumann TPS to the more modern SLA coating. This goes way back to 2007. And what I found is the SLA compared to the TPS reduced the failures and the bone loss by about 50%, which is significant. And I did publish on this, as I mentioned. This is up to 10-year follow-ups. So these are all my cases. We had a failure rate of about 5% versus about 2.5%. And success refers to bone loss. So take my word for it, failures and bone loss was reduced by about 50% when we went to the SLA surface, and the TPS was discontinued years ago. Another question. Someone said, why did you change implant surfaces? And I said, gave an example that we had some older surfaces that hydroxyapatite coated, for example, that showed 25% failures in my hands and other publications that didn't show up till 2 to 5 years post restoration. So some of the older surfaces have been reported to show failure. So I'll tell you right off the bat that that's true. And the second one is there can be other etiologies for late failure, such as thin bone. So if you think both of those are true, the best answer is C, A plus B. And that's pretty much what everyone has. Moving right along. So are we done yet? Considering longevity, let's just summarize. So we redid the mandibular prosthesis 17 years after that initial rehab was done. And we had 3 implants in the lower left and new crown and bridge from the 3.3 to the 4.6. Then a year or two later, we had to redo the maxillary prosthesis. So now we're 19 years out from initial rehab. And what we did was a 6 implant prosthesis from 16 all the way to 21 in 2 sections. And we redid the crown and bridge on the natural teeth from 22 to 26. Then that new prosthesis that we did lasted 6 years. And that's, remember, that whole thing popped off with all that decay. So at that point, we removed the rest of the mandibular teeth and just did implants with that immediate restoration technique. And you saw on the lower left, jumping ahead, that we did end up losing 1 implant at the 3.5 position, and we converted to a 3-unit bridge. That's jumping ahead to 16 years. We went out of chronological sequence a little bit because I wanted to show you the lower left in its entirety altogether. So at this point, the only natural teeth remaining are the upper left, the 2.2 to 2.6. And so what do you think happened there? Well, no, we're still not done, because the 2.2 started to show root decay that we noticed only in 2002. And that was 4 or 5 years after we did that new bridge in the maxilla. So it's just ongoing, it just won't stop. So there's the 1998 periapical when the new bridge was done, no decay there. But look over here, 4.5 years later, how the heck does that happen in 4.5 years? Maybe you have some theories. So what I did at this point, just to salvage the bridge, I just cut this through and just took out the root surgically and left the existing bridge in place. I mean, yes, there was a gap as the tissue shrunk, but that was the least of our concerns at that point. At this point, my father's fairly ill with severe diabetic issues, and believe me, aesthetics is not a concern. So we want simplicity. So that's what we did in 2002. And are we done yet? I'm sorry to say still no again. So we did that root resection in 2002, and 3 years later, the tooth behind it, the 2.3 fractured, the root fracture. Maybe there was too much force from the cantilever we created at the 2.2. And then after that, another year later, the 2.4 and the 2.5 started breaking down. Let's see how that looks clinically. So I'm giving you a little preview here. So there's the vertical root fracture happening a couple of years after we lost the 2.2. You can't really see it, but I did the same thing. I sectioned out the root. Now we've got a double cantilever off the 2.4, 2.5. You see, there's the 2.2. We did the root resection. Now I've just done another root resection at the 2.3. We've got a double cantilever. So we tried splinting it with some sort of amalgam wire splint just to get some support on the mesial, and you could see it already cracked by the time I went to take my photographs. This did not work out well. And as we go along, another year or two down the road, we're seeing a lot more bone loss and attempt at a restoration. That's in 2006, and in 2008, you see how much worse that is. It's totally decayed, and periapical lesions. And at this point, we have to remove this upper left ridge. Well, at this point, my dad's very ill and his bone's not great. And he's not going for bone augmentations. He doesn't even want me to try to do mini implants, just to do something. At this point, he just succumbs to the upper left edentulous area, you see, with a removable partial denture. And that sort of brings us to the end of this case. So let's just review what we started off with. History of basic emergency care. At age 55, had the full mouth rehab. He had these risk factors we talked about. He had all these treatments. We had a 33-year follow-up. Let's summarize the longevity issue, which was the theme I introduced at the beginning, which is an important message that hopefully we'll take away from these cases. The initial rehab on the natural teeth survived 17 years in the mandible, 19 years in the maxilla. When we redid the maxillary and mandibular prosthesis, the natural tooth sections only lasted 6 years and 8 years. And those failed a second time due to recurrent caries, and they didn't last nearly as long. The redo prosthesis that we did that were all implants survived the patient's lifetime. 9 years from the 4.6 to 3.3 and 14 years at the 1.6 to 2.1. And again, they would have lasted probably forever, but it only goes up to as far as the patient lived. So we had up to 17-year implant, and which really meant a lifetime survival on 14 out of the 15 implants. Just that one implant that we removed at 16 years that I showed you, possibly due to thin bone and or TPS coating at the 3.5. The natural tooth failures were primarily due to recurrent caries, which seemed to be accelerating with age and deteriorating systemic health. To summarize the statistics, the survival lifetime for the implants was 93.3%, 15 to 16. The survival rate for natural teeth was 0% because he lost every single tooth eventually. So in this particular case, and I'm not saying all cases, but in this particular case with risk factors of recurrent caries, bone loss as well, implants had a better long-term prognosis than teeth. Big time. Well, let's go on to case 2. How am I doing for time? Good. Here's a second case, and this case will go much quicker. So I know that's a lot of information I threw out at you. And as I say, I can send you the article if you want to review it again. But you get the idea that in this particular case, in hindsight, with that recurrent caries, if we could do things in hindsight, we would have removed possibly all the teeth and just done implants. But as I say, every case has to be evaluated individually. All right, let's look at another case. Very interesting, totally different kind of case. I saw this patient when I was in my post-grad program working on weekends in a dental office. 1978, the patient was 22 at the time. You could see he had aggressive generalized periodontitis, early onset. I'll show you the radiographs in a sec. You'll see some very interesting lesions around the 3.1, 3.2. And later on, he developed a lot of root abrasions and root caries. So you'll see how we have some very unique diagnostic and prognostic challenges at the 3.1, 3.2 with perio-endo lesions combined. I'll show you this in just a few seconds. You'll see how we did multidisciplinary treatments. We did not do implants on this patient. He couldn't afford them. And remember, we weren't doing implants really till the late 80s on a more routine basis. And he never could afford them, even when we offered to them later on. And I had a 41-year follow-up on this patient until he started off at 22 until he was 63. Again, I have a published article on this case as well that I'd be happy to send to you. You just have to email me and tell me what you want me to send you. I can send you these 2 cases. I have a series of 4 articles on the evolution showing you all the mistakes of the past. I have 5 articles on risk factors, which, as I mentioned, I have a 30-hour lecture on that. And I have what I'll call my career paper published fairly recently. It's a 65-page article that occupies the whole journal that goes into detail of all the risk factors with 15,000 implants that Chris mentioned I followed carefully with a specialized computer program. So here's our 22-year-old patient in 1978. You can see there's some crowding, recession. You can even see calculus, a poor bridge. But let's look first at the 3-1-3-2 area. Here's the 3-2. I mean, I can probe beyond the apex. Let's look at the radiograph. That's why. Now, the 3-2, this is important, is non-vital. The 3-1, I can't get a pocket clinically, even though it looks like there's no bone on the distal, and it is vital. So this is critical, what I'm telling you, and helping you to make a diagnosis. We have a combined perio-endo lesion here. And the question is what came first? The perio pocket just went down and devitalized the apex, or did this start out as an endo lesion that worked its way up into the sulcus? No history of trauma or restoration. He has generalized aggressive periodontitis. So I'm telling you, this very likely was a primary periodontal pocket that went all the way down to the apex, devitalized the apex. The 3-1, as I said, has no pocket and tests vital. So think about that as you're thinking what we're going to do with this area. Here's the full mouth series. You can see lots of bone loss around the molars, a poor bridge, lots of calculus, quite unusual for a 22-year-old. He had already lost this lower right molar by the time I saw him clinically for follow-up. So you could see it's that molar incisor form of periodontitis that used to be called localized juvenile periodontitis, but in his case, it's more generalized, and he is bicuspids and molars are all affected. Quickly, the models, again, you see there's crowding. Let's think about what we're going to do here in the 3-1-3-2 area. Keep the crowding in mind. I'm giving you a little hint. The occlusal view, that's a poor bridge, needs to be removed. He's already lost the 2-6 and the 1-6. He's already lost the 3-6, the 4-6s. I'll use the term bombed out, has to be removed. So let's look at this case and start thinking about your treatment for this case. Let's first look at this area. And again, I'll show you the radiograph. What are you going to do? Well, I can tell you with the primary perio and secondary endo lesion, the prognosis is hopeless. Don't waste time and money doing an endo. Not if it started off as a perio pocket. That tooth's got to go. The question is, what about the 3-1? It looks terrible on the radiograph, but remember I said it tests vital and you can't probe a pocket. Is there a chance the bone radiographically will come back once the 3-2 is gone and the lesion heals? If there's no pocket, it means the connective tissue is intact. So there is a chance that tooth could recover, at least radiographically. So what do? Well, initial therapy, scaling, root planing, oral hygiene, extraction of 3-2, and the first molars, they had to go. We wanted to do ortho to realign the crowding in the lower incisors because we had the extraction space from the 3-2. So a wax up confirmed that all the spacing would work out well. But we'd have to really check carefully that 3-1 if we're going to move that 3-1 orthodontically into that extraction site, which was a humongous periodontal lesion. And we might lose the 3-1 too. And we're going to do ortho, perio, endo if needed, pros. Definitive periotherapy, I did do periodontal surgery in the molar areas, but the bone loss was so severe, it was compromised, even at that time. It was an open clean out. I couldn't definitively eliminate the pockets. And maintenance therapy, and he continued in my office up until age 63. So that's initial treatment. So that's what we're doing. I didn't do the ortho. This was done in the orthograd clinic, but it's fascinating. Follow this radiographically. At 4 months, I said, uh-oh, what the heck are we doing? Is this any different than moving a tooth through an extraction socket because it was a lesion, a perio-endo lesion? Here's what it looks like at 9 months. Here's clinically how it looks at 9 months. We're getting there. Here's what it looks like at 11 months. What does the radiograph look like? There. At 18 months, there's the 3-1. There's the bone. Amazing. At 2 years, it looks good. At 15 years, it looks good. At 35 years, it looks good. See all you young whippersnappers? When you have a gray beard like me, there are advantages. If you document your cases well, it's wonderful to have these long-term follow-ups. Next question. Concerning this perio-endo lesions that I mentioned, combined lesions can either be endo or perio as the primary lesion. Number 2, primary perio with secondary apical endo lesions have a poor prognosis. Is only one of these true? If they're both true, you choose C. We're supposed to pipe in music from Jeopardy. Da, 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 da. Maybe we'll work on that for the next presentation. Okay, so pretty much both are true. So let's move on. So the answer was C. Answer was C. Both are true. Both A and B are true. So let's again recenter ourselves. Here's what we started off with in 1978. And we did initial therapy. We replaced that ill-fitting bridge. We removed the hopeless teeth. We did perio surgery in the 4 sextants. We did the ortho aligns. What I haven't shown you yet is the patient did have conventional fixed bridges in the 4 posterior sextants because he was missing the 4 first molars. And again, this was done in 1979 or 1980 at the Mount Sinai residency program. He continued with perio maintenance in my office after I graduated. Now, let's move on. What happened from 1980 to 2007? And I'll give you a preview on this title slide, and we'll show you some clinical slides of this period of time. He continued to lose perio attachment around the molars despite good hygiene and 3-month maintenance. Well, that's what happens with a small percentage of patients who have a genetic susceptibility to attachment loss, generalized aggressive periodontitis. They're also prone to bone loss around their implants down the road. If you remember, I showed you that statistic. It's double the failure rate. We'll revisit that slide at the very end. So he ended up, after 13 years, losing the maxillary second molars, which were the abutments for those 4 bridges. So those upper bridges lasted 13 years. He declined implants at that time, so a maxillary cast partial denture was fabricated. Now in the mandible, and again, he had, remember, 4 posterior bridges, he needed a new bridge after 18 years. So the lower left one lasted 18 years. He had decay, needed an endo. I guess for whatever reason, they redid the bridge at that time. I didn't do that. But then after that new bridge was done, 5 years later, he developed an advanced perioendo lesion on the 3-7. And I'll show you that in a moment. And then I did a root amputation because it was double abutted to the second molar, or to the other molar, to the third molar, I guess. But even after that root amp, that lasted another 4 years, and then 35 fractured, and he had to have that lower left bridge removed also. So again, here's already in 1993, he's already lost the maxillary second molars and lost the bridges. And these third molars have a lot of attachment loss. They are not suitable fixed bridge abutments. He's wearing a maxillary partial upper denture with provision to add those third, to convert to a free end when he loses the third molars. Now the lower right bridge is still surviving even after 18 years. And on the lower left, I mentioned he developed endo on the 3-5. A new bridge was done to the third molar, and that bridge lasted 18 years on the lower left. But even that new bridge, which was double abutted from the 3-7 to the 3-8, don't ask me on the lingual what this is. I don't know what the patient is doing. It doesn't look like decay. I don't know what he's cleaning his teeth with, maybe a file, I don't know. But radiographically, this is what that abutment looked like. So again, to salvage the bridge, I just sectioned through that root for as long as that bridge would last here. So there's the sectioning. And as I say, that was only 5 years after this bridge was done. This is the second bridge now. And then 4 years after this, he fractured the 3-5 and lost the whole bridge. The lower right bridge is still hanging in there. Now we're seeing something else starting to happen. We're starting to see abrasions. Look at the way that's kind of hollowed out here. And sure enough, 3 years after this radiograph, he shows up and 2 incisors have snapped right off. And look what's going on with these roots up here. Again, I don't know what this guy's cleaning his teeth with. I don't know what that's from. But this is real life, folks. When you follow cases for 30, 40 years, things happen. So he lost those 2 teeth. So here's where we're at. And I want you to start thinking, what are you going to do? We mentioned in the maxilla, he's wearing a partial. We know he's going to lose the 3rd molars one day. We now know we're going to lose the 45 as well. And what options can we offer him? Let's say he won the lottery, and anything you say, price is no object. What are our options? Well, right now, he's wearing the partial up to this point in time. But we could diagrammatically, let's revisit that in a moment, because I'm going to say, what's your plan for the future? So again, just reviewing, I won't read it out to you because we just went over this. What's our future treatment options? Of course, we're going to continue with maintenance. We know we're going to lose the 3rd molars. We know he's got dentures now in the upper and lower, but what's your definitive implant dentistry plan? And here again is what we're dealing with. So one option is to do something like this. He needs sinus bone grafting to be able to put implants in the back. And we could, in theory, replace the missing teeth with implants here. So this is one option. But remember, like in my dad's case, I said, well, based on his history, these abrasions, you see they're even restored here. Is this a smart option, or should we at this point just remove them all and just do full mouth implants? Now, this is not his case, you know, whether it's a all on 4 case or it's something like this. Like, what do you think the better option would be? And not going to give you an answer because we left him with partial dentures, but it's food for thought. And this, again, like I say, is one of the important themes I'm trying to present to you with these 2 cases. So again, to review, this patient, up until the time I met him, had substandard care. We started with comprehensive treatment in 78. I mentioned the risk factors. This is the same as the introductory slide for this case. This is a review of the timing, again, with the theme of longevity. So remember, we removed the first molars, the 32, we did ortho, perio, bridges. So of those bridges, 13 years, he lost the maxillary bridges. 18 years, he lost the lower left bridge. 9 years after the lower left bridge was redone, he lost it again. 37 years after, he lost the 4-1 and 3-1 because they snapped off. And that lower right bridge was lost after 40 years. Tooth loss was mostly due to periodontitis and in some cases caries. In all, the patient lost 14 natural teeth in the time I saw him. That's 43.75% of his dentition he lost over that period of time. Now let's revisit, I'm almost done here, folks, some from a compilation of many studies, my own statistics here in orange. On average, and it's an average, remember, you're looking at 2 to 8% failure rates, depending which study you quote. If we look at the literature with just aggressive periodontitis, the failure rate's twice as high. That's the literature in a brief glimpse. There's thousands of articles. I'm trying to give you an honest bottom line summation from a compilation of the literature. Let's look at the 2 cases we just looked at. Let's look at the failure rates here and see how they compare with the published averages. Well, in my dad's case, implant loss, 14 out of 15 survived his lifetime. So we had a 6.7% failure rate. It's in the ballpark with what the literature shows. Tooth loss was 100%. Well, that's a little bit more than this study showing 2 to 5% on average. Well, my dad wasn't the average patient. He was highly prone to redecay. Let's look at case number 2. Although we didn't place implants because he had generalized aggressive periodontitis history, I'll say his failure rate was probably closer to the 10%, like the literature shows. I'm not going to say it's 5%, even 10%, but his tooth loss failure rate was 43.75%. So conclusion, at least in these 2 high-risk cases, aggressive caries and periodontal bone loss, dental implants would likely have a superior rate versus natural teeth. I'm not saying that's the case for everybody. You have to look at each patient individually. Last question. concerning the longevity of implants and teeth. Dental implants in healthy patients have been shown in the literature, 10 years, about 2 to 8% failure rates. Is that true or false? Natural teeth and well-maintained 2 to 5%. Sorry, dental implants 2 to 8%. Actual survival rate depends on prognosis and risk factors. Is that true? Failures may be greater with high risk factors like susceptibility to caries and periodontal disease. Is that true? Now, if they're all true, choose E, which is the better answer. And 19 out of 21 have chosen E, and that is the correct answer because they're all true. So as we started the website, and Chris mentioned what our learning objectives were for today, showing you a couple of interesting multidisciplinary cases, some unusual diagnostic challenges like that perio-endo situation. Patient-centered treatment, you may not have agreed with what I did. Maybe some people would say I'm not doing ideal treatment all the time, but to me, patient-centered is practical treatment for real people, many of whom have budgets. And I showed you cases with long-term follow-ups of 33 and 41 years, and we'll end the way we started, saying that these two cases hopefully highlighted the importance, the critical knowledge you need of understanding or appreciating the long-term survival of teeth versus implants to help you in your everyday clinical decisions of giving your patients evidence-based results of when a tooth you're recommending be saved, as opposed to when you think you're suggesting it should be removed and replaced with an implant. So I hope I haven't bored you. And certainly I would be happy to entertain any questions and remind you that I'm happy to send you emails, answer your emails, speak to you. My email is murray@murrayarland.com. I mentioned those articles, so I can electronically send them to you quite easily if you like. Again, I want to thank Aaron for helping us with the tech. I want to thank Chris for moderating. I want to thank TMFD for sponsoring the evening. And Chris, I'll hand it over to you.
Yeah, great, Murray. Thank you very much for all your input tonight. It's been a fascinating presentation. We don't have any questions at the moment, although we might get some as we come along. But, you know, as a layperson, first of all, being in the financial side of the dental industry for a while, I've often heard the expression save the tooth. And I think tonight you gave us a new perspective that that may not always be the case. You've also had the great opportunity to see the evolution of the industry over the last few decades. So can you give us a bit of a commentary on where things are at today? Is there a technique or a material or something that really stands out to you that is
Okay, I'll try
implants?
I'll try to highlight a few things that have changed. I mean, I can tell you some of the problems we dealt with in the early days was defective surfaces on implants, which I mentioned. I use hydroxyapatite as an example where we had a lot of late failures, which are the worst kind. Implant fractures, when the titanium was a weaker grade 1 titanium in particular, the implants are stronger, they fracture less often. From a technology point of view, a huge development has been the CBCT or the cone beam CAT scan technology that we have, seeing things three-dimensionally. And related to that would be computer-guided surgery, navigation type procedures that are especially helpful for surgeons who don't have a lot of experience. And the whole digital revolution of how things are done digitally today on the prosthetic side. Like in the last few years, we had a digital scanner in our office. So we would do a digital impression of the integrated implant for our referred patients. And I know a fellow who bought my practice, Mark Nicolucci, still does that. So I want to give him a shameless plug. And we were happy to do that at no charge to support our dentists. So and even the fabrication of the components more and more is being done digitally. Well, digital radiography, that's old news already. So the digital revolution would be another big one. There's a lot more emphasis now on immediate restoration, teeth in a day, I'm a little cautious about that. And I alluded to that when I showed you my dad's case where we did a case like that. But we really were careful with all those mitigation factors that, over engineering, splinting, rigid prosthesis, occlusal control. So those are some of the main issues that come to mind. But, one thing that hasn't changed is that there's a real human being attached to that tooth or attached to that implant. So patient management and caring and being responsible and not too cavalier, that hasn't changed, Chris.
No, there's always a person at the end of that tooth. That's true. There's a question here in the chat box. Additional thoughts on Austell?
Well, I mean, Austell is a measurement tool to measure the initial stability of an implant. If I'm incorrect, let me know. I never used one. That's why I hesitate slightly. When you place an implant, you know how much torque you've applied to get it fully seated. And that's the guide that I would use, that you want to have at least 25 Newton centimeters of initial stability, and 50 or more is even better. The Austell is a very sensitive measurement tool that, in theory can help tell you when the implant's ready to integrate or to be restored. I never found it to be a necessary and practical tool to use in everyday private practice. So maybe for research, it might be better because maybe you can fine tune some guidelines. So perhaps I'm not the world renowned expert on that, but that's my initial comments on that.
I do have another question. It's a little bit more generic, but after the career you had with specialty practice like yours, you rely a lot on the referrals from a general practice. Can you tell us what made a really successful relationship with the GPs that you were working with?
Thank you. And yes, I'd say 95% of our referrals or more came from dentists, not from the general public. As you got on more and more in your career and had more and more patients, you might have a slight increase in that patient referral, but never very much, actually. I mean, I think there were two things. Number one, treating everybody with respect, including patients. So, hopefully the patient goes back to the referring doctor and says, that Dr. Arlen, he's a nice guy. He treated me well. He explained things. And that's just a personality thing. And I think that's important. And of course, treating your referring dentist the same way. And number two is trying to do good quality work. And as I say, being reasonable and practical. And I didn't try to treat every patient like they're going to be published in a Hollywood magazine if that wasn't what they wanted. So I was willing to be flexible, and maybe for a full arch we would do a snap-in kind of overdenture instead of a fixed arch if they had trouble cleaning and there were issues with aesthetics, phonetics, and finances. I didn't have a problem doing a removable kind of prosthesis. It didn't hurt my ego, to do removable, which some people have an issue with that. So just doing what I call patient-centered treatment, trying to do good quality care, good service, good reporting, and treating everybody with respect.
Wonderful.
Oh, and one thing that really helped me was the study clubs that I ran. Because it really grew. It was about 25 years I ran it. From the first year, we had 20 members, and at one point we had 457 members at its peak, and we were doing like 20 evenings and 8 full days every year for like a $500 annual membership fee. And of course that got me known to a lot of dentists because I did a lot of those presentations myself, and took about 5-10 years to kick in, but that really helped my reputation, and it really helped the referrals, the study, the continuing education, because I would do this for perio and implants and invite my referring doctors and their staff to come for free. and instead of buying them a Christmas gift that they forget who gave them what. So I did it through continuing education, and over a long period of time, I think that was one of my differentiating features.
I remember those days.
Well, you guys were involved with them, and that's how I got to know you, and that's how I became a client, because TMFD would every year be a good supporter, and you'd sponsor 1 or 2 evenings every year and have your booths there for the full day. So you were an instrumental, one of our strong supporters. So you did more than your share in helping me run successful study clubs. So, and it all worked out great for all of us.
Yeah, I would say so. Well, I think that's all that we have for questions now. There was maybe someone had raised their hand, but perhaps I'd missed that. But there are no other questions at this point. So Dr. Ireland, I'd like to thank you very much. I think it's really amazing how you maintained patient records over such a long period of time. I hope our guests were able to benefit from seeing the life cycle of treatment and the challenges that can arise. A reminder to our guests that if anyone has further questions for Dr. Ireland, feel free to contact him by email at murray@murrayireland.com or through TMFD, and we can certainly help. As we close out here, I'd like to thank everyone for joining us this evening. I hope you enjoyed it. A reminder that PACE credits will be issued within the next couple of weeks. And I hope you'll be able to join us again for our next presentation featuring Nicola Elkins, who's the founder and CEO of Benefaction Foundation. Nicola will provide an overview of charitable giving in Canada, including tax-efficient ways to give strategically. She'll also talk about donor-advised funds, which is a wonderful way to create a legacy for you and your family on a long-term basis. This presentation is scheduled for Monday, May 15th at 7 p.m. and guests may register on the TMFD website under the Academy page. So as we close up this evening, I'd like to thank our speaker, Dr. Ireland, for his valuable expertise and insight, and of course to Aaron Carello for running the show. And thanks to you, our guests. It's been really great to share this evening with you. We hope that you found it valuable. Thanks again, and have a good night.
Thanks, Chris. Thanks, Aaron. Bye, everybody.
Good night.